All right, we are going to get started. Today we're in our second of our Ask the Experts video series, and I'm sorry I'm having a couple little issues, but here we go. When we talk about hospice, we like to say that hospice isn't about giving up, it's about taking charge. And I think this part of our education series today will highlight some of the ways that you can take charge at end of life. Just a little bit about Hospice of Southern Maine. We're a nonprofit hospice provider in York and Cumberland counties. We provide hospice services to over 200 people daily, wherever they call home, which could be at their physical home, in a facility, or wherever they live. We also have this is our new, for those of you who go down in Scarborough on US Route 1, this is our new hospice center. We're very proud of it. It just opened last year during the pandemic. But this is basically our touchdown space where our caregiving team stops in to get supplies, to have meetings. This is where we hold bereavement services once we can open more to the public. And this is where our admin team also lives. As part of Hospice of Southern Maine, the Gosnell Hospice House is also in Scarborough. We have 18 private suites here, and here we care for people who can't stay at home because their pain and symptoms aren't under control. So they can come in here to our inpatient facility. We also provide respite care here for caregivers who need someone to take care of their loved ones so they can take a break. So today, Jess Vickerson is going to be talking about having the conversation, how to talk about end of life. And Jess is a duly trained family nurse practitioner and social worker who's worked with seriously ill patients and their families for more than 20 years. She's worked in the community hospital and tertiary care settings, home health, outpatient neurology and oncology clinics, and inpatient hospice care. We're lucky to have her working with Hospice of Southern Maine as a nurse practitioner, and she supports the Gosnell House and the home program.
Good morning. So I'm so pleased to be here, and I was so happy to see so many signups this morning, particularly representing so many different disciplines, care areas, and aspects of healthcare. I'm certainly feeling grateful to be a part of this. So I started my career as a social worker on a bone marrow transplant unit in Boston, and it was there that I really started to think about the impact of serious illness on patients and families, and some of the ways that we use conversation, approach difficult topics, some of the ways it impacted their care. So I wanted to talk today about some of the skills that I've learned over the years to have these conversations. I would be remiss in not saying that so much of what I've learned has come from patients, their families, but also from my interdisciplinary team, my chaplain, co-workers, social workers, physical and occupational therapists, volunteers. I've learned so much from these folks as I've continued to do this work. So I want to start a little bit with where we find difficult conversations. And I would say that difficult conversations occur across the entire spectrum of healthcare in almost any setting. We talk about them a lot in the care of the seriously ill is happening around diagnosis, prognosis. In particular, anyone who's cared for patients or spent time with someone who's going through treatment for a serious illness knows that the moment of diagnosis can be a really high intensity and an impactful moment. I have met with many patients over the years who've been in treatment, sometimes 4 years, who said that they won't ever forget the way their diagnosis was shared with them or the words that were used. Similarly, in end-of-life care, I often hear the same about prognosis. I hear often people tell stories about what it was like for them when someone first introduced the word hospice or talked about end-of-life care or time being short. And so I think there's a real responsibility on us in healthcare to think about the way in which we approach these conversations, the way we're present during them, and sort of how we approach this part of medicine as a skill. We also tend to have a lot of difficult conversations around goals of care and preferences for care. We use that term in palliative medicine a lot, goals of care, and really it's what do you want your care to look like? What are your values? What's important to you as you continue through treatment for a serious illness? Difficult conversations also arise at various points during treatment, including, particularly in hospice, with significant changes. And sometimes this is the development of acute symptoms, a change in care setting, something significant changes in the family that impacts the caregiving. And finally, code status, how we talk to people about resuscitative efforts and what would happen to them and their chances of having good quality of life after an attempt was made. So these are some of the pivot points, but I really think about it, particularly today, as I know many of you aren't necessarily medical providers, as being part of all of our interactions in healthcare. And in that spirit of that, I'm going to use the word patient. I know that a lot of people here may have clients or loved ones or significant others that they're thinking about, but in my world, people are patients just now, so that will help me from getting tongue-tied. So the essential elements of difficult conversations, I think, really come down to these few things. The provision of ample time. You want people to really understand that your time is devoted to them, that they are sort of the focus of the time period that you have. I think in healthcare, we can all recognize, however, that time is in short supply and that people are spread quite thin. So I always say, if you know what kind of time you have ahead of time, it's always good to say, today we have 30 minutes to talk about your treatment decisions. I have an hour today to be with you for this visit. And if you have a finite period of time and you are concerned that you may have more to do from there, also predicting when that follow-up time will be. So I have 30 minutes to talk with you today about our next steps, and I hope to meet with you again next week to follow up. Maybe one of the most important things that I'll talk about today is the use of silence. I think we, in our culture, have given silence a very bad rap. We're very quick to fill silence. We tend to think that because we're uncomfortable in silence, other people are uncomfortable. And not only does good reflection on conversation prove that that isn't true, research proves that that isn't true, that people often use silence to sort of take in what they've heard, to reflect on it, to think about their next question and to sort of integrate some of what they've heard. So if you're not comfortable, and I'm not someone who's super comfortable in silence or hasn't been in the past, I really encourage you to practice it, to sit with silence, to, even role play if you can, or use opportunities in your own personal life to sit with silence and really allow the other person to continue to reflect or continue to talk. Attending to body language, this is always a funny one as I'm giving talks like this, because you'll see I talk with my hands and I really lean in. I tend to be someone who is very physical in conversation, but I think it matters. I think it matters if you're facing someone, if you're making eye contact, if you are seated with your feet on the floor and your hand isn't on a door, if you're not standing. I sometimes think of this in medical offices in terms of having these conversations when people aren't in a Johnny, or if they're in a hospital bed, they're comfortable, they're covered. We know we've attended to the dignity piece. So your own body language, and also attending to the body language of the person you're talking to. So if suddenly you see someone tense and their arms are crossed across their chest, and there's a sudden shift, that can sometimes give you some cues to check in with yourself to think, what messages am I sending now non-verbally? What do I need to consider as I continue to proceed with this conversation? The next thing is really important, and I think it's a struggle for many of us in nursing and in medicine who have really learned to use medical jargon as a way of communicating, to not use that during difficult conversations. I've almost never met a patient who cares about their hepatic or renal function, but people want to know what their liver test shows, and they want to know if their kidneys are healthy. They want to talk to you about their body in terms of themselves as a whole person, rather than systemic body parts or systems. So I really encourage you, even as you're preparing, to think about how are you going to approach the medical information so that it is not jargon. This may be among the other most important things that I communicate to you today, and that is really doing your best to avoid platitudes, false reassurance, and any promise that can't be kept. This matters. It matters when you're talking to people about difficult things that they know, that you are telling them what you know and what you recommend or suspect from a place that's genuine and honest, and that you are going to walk with them through the next steps in a way that you say that you will, and that they can count on you to do that. So I think if you take away two things from this slide in particular, I would say really thinking about how comfortable you personally are with silence, and thinking about maybe any of the platitudes or false reassurances that we tend to just use, colloquially in our conversation with people, and trying to find a way to take them out of the conversation. So preparation, like so many things, is really the key to starting off on the right foot. I think your environment matters. Just from the registration list, I see that you're all having these conversations in a variety of places. And sometimes we can't totally control our environment, but to the best of our ability, ensuring that it's quiet, that it's free of distractions. Can you turn off your phone? Can you turn off your pager? Can you let people in your office or in your milieu know that you need this 30 minutes to be uninterrupted? And if you can't, as many of us can't, for a variety of reasons, can you predict why you might need to be interrupted or when that might be? So I'm expecting an emergent call in the next 30 minutes. You may find that my nurse interrupts me at some point. I want you to know that this time is important, and we'll get right back to talking when we can. And the other key piece of preparation is, do you have all the information that you need? Have you reviewed advanced directives? I would argue that advanced directives are themselves difficult communication. Sometimes they're complex, they're emotional, they're loaded, but I think the use of those documents, especially if they've been completed prior to your discussion, can be really helpful in reflecting on people's values, their wishes, the things that are important to them or that they may have stated previously as you're working through this real-time situation. And then, of course, any recent HPI or history of present illness, anything that's happened recently that would really inform the decisions that you make with your patient and the recommendations that you have. So in terms of VIP slides, I'd say this is my other VIP slide. And I did receive a question prior on sign up about what was my most difficult conversation. And I'm happy to share that I find conversations with parents who are seriously ill, talking with me about the impact on their young children, extraordinarily difficult. I am a family nurse practitioner, but not a pediatric nurse practitioner, and I have young children. So I noticed that when I'm having these conversations, I have to be really clear with myself about a few things. I have to make sure that I understand what's my stuff, what's my issue, what's my worry about my own family or my own children or my own parenting, and to keep that separate and not project that on the situation, to really ensure that I'm checking my stuff to the side and really focused on this person and their life and their concerns. Those conversations are difficult for me because they're emotional and they're complicated, but they also really force me to be introspective and to be aware of the way I'm coming across, the things that I'm saying, and the judgments I may be making. So with that, I would say check in with yourself. Do you fully understand what's going on? Is there something that you need to clarify? Probably more importantly, do you know what your fears are? Are you afraid to share this information? Are you afraid that you may face this experience yourself or might be in this position? Specifically, how comfortable are you with the word dying? I think culturally we've done a good job or poor job, depending on how you look at it, really loading this with a lot of stuff that, it takes away from dying as part of life, and much like birth, a time in life where we really need to access our resources and attend to emotion. And if we're not comfortable with the word, it can be really difficult using it with other people. How do you yourself deal with difficult conversations in your own life? Are you someone who really leans in and who goes for the hard stuff? Are you someone that tends to be a little more laid back and not necessarily comfortable? I think if you can reflect on how you do this, it can be really helpful when you're sitting in a room to think about how you may be coming across or what you might be projecting or sort of assuming in the situation. I think being in tune with that is important. And what barriers do you anticipate? Do you know this person, this loved one, this client, patient well enough to know that they may have a certain objection, or they may take it particularly hard because of some other experience in their life? So I think going in with a sense of your barriers is really essential. I think this is sort of an obvious one, but just ensuring that you are thoughtful about gathering appropriate people. Who are the actual decision makers? Sometimes an advanced directive will note a decision maker who's not actually a caregiver. So do you have the right decision makers, the right caregivers? Are other providers, able to participate? And I would say other disciplines. The fact that hospice is a multidisciplinary team is intentional. It's on purpose. And I really do best when I have difficult conversations, when I'm able to have my chaplain and social work friends present. Our hospice at IDT is richer and the care is more comprehensive when I really think about how those people's skills contribute to the skills that I offer, and vice versa. So I tend to start the conversation with sort of some general assessment questions, which can be done in a number of ways. But for me, these questions tend to be roughly the same. They tend to be, tell me what the doctors and providers have told you. Can you describe your sense of how things are going? What's your sense of your diagnosis? And tell me about the last 3 to 6 months. I tend to pick that time period because usually the events or the functional changes, people's overall status over the past 3 to 6 months really informs the kind of decision-making they might have ahead of them. These questions are evidence-based. You'd see here that I noted fast facts. They're questions that people use quite frequently, but they're also really good open-ended questions that tell you a lot of information. They tell you what people are thinking. They provide an opportunity to identify gaps in information, disparities in expectations, areas that need clarification. And I think you can learn a lot separate from recent, history of present illness, from what people feel they know or what they feel they've been told. So in that vein, it's an opportunity to review, correct, and to add information. It's essential that you acknowledge how overwhelming and confusing this may be. It just is. It's overwhelming and confusing for patients. It is often for their providers and their families. And I think it's good to normalize that. And the next step I really try to attend to is to ask permission to review and proceed. So I use statements like, can I bring you up to date on what we know? Or would it be okay today if we talked a little bit about my concerns? I was hoping today that we could talk about what's been happening in your treatment and what we should consider next. And when you ask permission, then you often get a sense of shared communication, people talking together about what matters to them based on the history that you just got or the understanding that you just got with your open-ended questions. And then after the meat of that conversation, where I again use things like silence, body language, really, focused attention on myself and what I'm bringing to the table, I like to end with a bottom line, something like, so as we talked about today, it really seems like your liver is getting worse, or I'm afraid that things are not going to improve. Time is short. I'm concerned that we need to talk about what the next couple of weeks could look like. And that bottom line statement is not only really important, but I think it's good to use some of the language that you used previously in your conversation to really highlight what you've talked about and some of the points that you really want to make sure that you're communicating. I just want to say, I realize I'm going pretty quickly from slides here, but we do have a lot of opportunity for questions, and we can stay after if we run a little over for questions as well. I know people submitted some, and I'll be sure to get to them. So once you've sort of asked for an overview, asked permission to proceed, provided a brief recap. I think it's time that you provide time for questions and really sit quietly and allow people to ask. And these are the questions I get most frequently and that I find the most difficult. You know, how long do I have? How short is time? What will happen? Maybe the, you know, sort of that most important question for all of us who are interested in this kind of work is, will there be suffering? What do we do next, and who will be able to help us? These are big questions, and nobody expects anyone having these conversations to have all of the answers or to predict what will happen. But I do think it's really important when you're being asked these questions to name uncertainty or say when you don't know. Saying I don't know is one of the most high level skills that I think I've learned over my career. I wasn't always comfortable with it. I felt like I should know, but I think it really is a communication and a relationship builder when you are honestly able to say, I don't know. I don't know what will happen next. I hope there's not suffering. My hope is that you have this much time, or we will do everything we can together over the next X period to ensure that we address suffering as one of your primary concerns. And then again, a wrap up. So you've answered your questions and you provide a very brief wrap up of the discussion, the questions that you've answered. And again, brevity is key, using key language and really being sure to avoid euphemisms or jargon. So today we reviewed your options for treatment. We agreed that hospice might be the next step. I will make a referral today to hospice and you should expect to hear from them within 3 days. So reiterating next steps clearly, action steps, a time frame, and who will follow up. This really closes the conversation, I think, in a way that helps people know what to expect next. And so this is my final slide. And I think if you had told me this 20 years ago when I was green social worker and I was putting my foot in my mouth all the time or getting in the car at the end of the day thinking, oh boy, I should have said, or I wish I'd said, it's good for us to consider this conversation as a skill. The more you practice it, the better you do. The more you talk, the more mistakes you make, you know, as long as you're genuine and honest and you're present, the more you learn at each time you do it. So I have a couple of just little pieces of advice around that I would offer. And then you can see there are some paradigms available. The Serious Illness Communication program and Fast Facts can offer some additional information about some things to use. But these are two things that I do. So the first is I use some canned language. So I have worked in a variety of settings where I hear people describe hospice, and I think it's sometimes different from person to person, and that's okay. But if you develop some language that you are comfortable with about what hospice is or what palliative medicine is, and you get comfortable with it, using it frequently will feel more comfortable. So I'm not saying canned language that's phony or that isn't authentic, but canned language that really you feel comfortable with around hospice provides, hospice is, kind of stuff, so that you get it out clearly and you're not sort of tripping over your words each time you do it. And the final thing that comes from the Serious Illness Communication program that I use all the time is this wish, worry, wonder paradigm. So I really wish things were going better, but I worry that if we don't talk today about how quickly things could change, we could miss an opportunity for you to make some plans with your family. I wonder today if we should talk about next steps. So just very quick, and it works in a lot of scenarios, but it's a good place to start if you're really trying to practice these conversations. So we're going to go to questions.
Okay, that was great. So we've got some questions that were submitted, and I know that we are hitting up against noon. So if anyone has to leave, then this is being recorded. It will be on our askhospiceexperts.org website afterwards. So if you can't stay, you can come back and see if your question was answered. And at any time, if you have any questions for us at hospice, feel free to go to that same website and submit them through there. So this is kind of a long question. I understand once a person signs on with hospice due to Medicare, the costs are then assigned to hospice. A dear friend learned this the hard way when her husband was in distress and asked her to call 911, and she then called hospice to let them know. They were upset that she called 911 and that the patient was taken to the hospital. In another scenario, she later had a friend who was sent home with hospice, and when she was unable to set him in bed and called hospice, they told her then to call 911. These scenarios contradict each other. Please share who is responsible once you sign on with hospice.
So that's a great question. So I certainly couldn't speak to each of these scenarios in detail since I'm not familiar with them, but I can tell you a few things that I think are really important as we think about end of life. Medicare does have a hospice benefit. So when you enroll in hospice, you do sign on to your Medicare benefit, or if you have commercial insurance, it's often very similar. And the hospice team does assume the cost of your care. But I really think of that as very separate from the issues in this question in terms of triaging what's come up. So I think what I would say, and I think my colleagues here at Hospice of Southern Maine would say, is that we hope that when we first meet folks and get to know them and their preferences for care, that we really are beginning to plan for stuff that we think may come up and how to manage it, especially in emergencies. Now, you can't plan for everything, but I think the message I would convey is that a call to hospice first is always really important, because we might have encountered the situation before. We might know something about you and your family, or have predicted something that we can help triage the situation in the home, particularly as we know many people want to be home. That doesn't mean that you're not allowed to go to the emergency room. It just means that there's a way we can manage it that aligns with your preferences of care. It's nice to have the opportunity. Conversely, there are times when we can't. Stuff that we do at home can't be provided, or can't make the situation better. So I think of someone with end-stage lung disease who falls and breaks a bone. We can't do an X-ray in the home. We can't set a cast in the home. And if people were really feeling like their quality of life would be improved with attending to this, or their symptoms would be managed, then yeah, we might say, I think it's important for you to seek care outside the home. And I know that our local EMS services are often very willing to help people who've fallen at home up out of bed, particularly if it's between hospice visits. So I'd say the answer is sort of somewhere in the middle on this question, but it's a great question.
Okay, great. This is kind of a tricky question. When families can't agree, what do you suggest?
So this is a tricky question, but this is where I would go back to some of what we talked about before and say, find your interdisciplinary team, get everybody around the table. And this is so common. It's common at diagnosis. It's common at prognosis. I've seen it play out countless ways over my career. And I think what is most important is to really sit with folks and figure out where they're coming from and what their concerns are. Sometimes when you really sit down and dig deep with people, you find out that they don't disagree with the plan. They are scared, or they have a worry about, will mom or dad have pain? And so they don't agree with home-based care because they're worried they can't keep mom or dad comfortable. Most often, if you revert back to the listening, the really sitting with people and helping them reflect on their goals and preferences, you can understand where people are coming from and why people in the same family might not be aligned. That's where I start.
Sounds like a good place. What is the best way to talk to people who want to pursue treatments that won't be helpful and may cause more harm in the end?
Right, this is a tough one too. And again, something we see a lot. I think this is one of the central struggles of the medical system. How do we know when helping has become hurting? And I'll just say, I met with a patient earlier today. She was lovely and she gave me permission to share this. And she talked about hospice as a state of mind. And she said she didn't think that she'd live to see another year of hanging Halloween decorations when she was diagnosed with a very aggressive cancer. And that she felt like had she gone through chemotherapy, she really would not have lived for another Halloween or another Christmas. And where she came from it was about her values. So I tend to go back to that place of, what is most important to you? Like, what do you imagine your end of life? If you knew that you could extend your life by a small period of time, but that you'd be much sicker during that time, are you willing to make that trade-off? What have you seen other people in your family go through? Or have you had experiences where you really felt like pursuing treatment was the only option, but in retrospect, you look back and thought, geez, had I known? And I think I speak for a lot of us in palliative medicine when I say we hear that a lot. boy, if I had known I was going to be that sick, or if someone talked to me about the trade-off I was making, I may have chosen differently.
Another question, what are some important decisions for the patient to make prior to going on hospice?
So this is sort of in the ideal world, I would hope that some of these decisions, the medical world had provided you with opportunities to kind of approach over time. So, it starts really early for most adults with an advance directive. What do you want the end of your life to look like? What kind of trade-offs are you willing to make? What do you think about artificial hydration or nutrition? What is an acceptable quality of life for you? And when would you be willing to give up sort of curative care for more quality of life? So I always think of advance directives. What kind of decisions would you make? Who would make decisions on your behalf if you couldn't? Where do you imagine the end of your life being spent? What does that look like? What do you assume when you say that? And I think back that also then to the trade-offs about a very common advance directive question is, would you want to have treatment of pain if it meant you would no longer awake or conscious, or it shortened the time until the end of your life? So really imagining what would be most important to you in that scenario and talking it through. And you can do that before hospice and you can do it on hospice. Our interdisciplinary team is very skilled with helping people get to these answers.
That's great. Next question, how do I ask someone if they want to die in their home?
So I think what I just said probably applies here as well. I think being comfortable with the word death, having had really the requisite conversations ahead of time about what we expect to happen, what our prognosis is, what kind of time we think someone may have, using that as a sort of jump off point to say, given that time may be very short, and I expect that you may become more short of breath or have more pain, where do you imagine your care taking place? I think I'll just say really quickly too, that I often hear people talk about home, not in terms of the physical location, but the way things were. So sometimes I do hear patients say they want to be at home, but when they say that, I do think that sometimes means when I could walk by myself or prepare my own meals or take care of myself. So getting to the real nitty gritty of what home is. Would you want to be at home if someone else were providing care for you? Would you want to be home if you were completely bedbound and no longer able to get out on your beautiful patio, or etc.? So I think, again, sitting with discomfort and leaning in and giving people the opportunity to really reflect.
Elizabeth asks, what is the availability and utilization for end-of-life doulas here in Maine?
So I don't know. Here we are with the I don't know. It's okay. I don't know the answer to that. I know that our Kathy Letty, who works here, is an end-of-life doula and works closely with them. So I have reached out to her to ask her for this information, and we'll try to get it to the person who asked this question as soon as we know. But I have not had any experience with end-of-life doulas.
Okay, well, maybe with this, where can I go to get more information and additional resources?
So at Hospice of Southern Maine, you can always call at 207-289-3640. You can go to our website if you Google Hospice of Southern Maine. There are other great websites like getpalliativecare.org. Fast Facts is one I mentioned previously, has a lot of good information, a little bit geared more towards care providers, but a lot of good information can be found there.
I want to see if we've got someone in the chat. Okay, someone who had to leave. And that's a good point. The webinar will be, like I said, it is being recorded and it will be on Ask Hospice Experts in the library if you want to share it with anyone else. And those are all the questions we got for today. So wonderful. Thank you so much for participating, everyone. And I know we had it, the next one was flashed up. It's November 2nd, and it's part of our November is National Hospice and Palliative Care Month. So we're doing 2 webinars, and they're geared more to the general public. One is just an overview of hospice, and one is kind of a chaplain's view of end of life and having some of these same kind of conversations with families. So I hope you can join us for that, and thank you for being here with us today.
Thank you.
We can answer her.
Live.
Do you want to answer her now?
Angela,
We have one more question that came in.
Angela Wheaton, are you still there? Maybe just type a yes if so. She asked a really great, good. Oh, technology, beautiful thing. Angela asked a great question. What do you say to people who are afraid of getting addicted to pain meds? So it's hard sometimes because being a nurse, I sometimes think in terms of the brain, you know, versus just in everyday language. But I often say something very simple like, your brain has pain receptors, and when you're using pain medicine and you don't have pain, it creates a different response, sometimes a euphoria or a high, as we like to think of it. But when you do have pain, your body is wise enough to know that the opioids or the pain medication needs to attach to those receptors, and that as disease progresses, we often need higher doses or higher frequencies of these medications to maintain comfort. Addiction at end of life is almost never a concern. Certainly it's a whole other thing. If you've lived with a substance use disorder previously and you're at end of life, there are some different things to consider, but we almost never are concerned about addiction at end of life. We're much more concerned about the alleviation of suffering and the maximization of quality of life. And I think if you talk to people about what their quality of life and function will be like, if they take pain meds and feel comfortable, they're often dissuaded from thinking about the concerns about addiction.
Good. I'm glad we could answer that.
Yeah.
Okay, thank you. Have a good afternoon, and we hope that you'll join us again for more of these sessions. Thanks.